related to our discussion today. I'm going to talk about cognitive behavioral therapy and specifically some techniques that fall under the umbrella of relapse prevention, which lives under the header of cognitive behavioral therapy. This is a pretty content-heavy presentation for the 30 minutes that we're allotted. So just a heads up, I'm going to be moving through a lot of it fairly quickly. The slides have information in there and worksheets and different things that I'll probably point out, but won't go into any detail. So if you're interested in utilizing any things that I discussed today, please just refer back to the slides. I just wanted to make sure that people had the information, but not necessarily do we have time to go into it in detail. So I'm going to talk about the basic components of CBT, so some of the tenets that fall under what CBT is. And then I'm going to go through some core relapse prevention techniques. One is trigger identification. The other one is urge management and urge surfing skills. And then the last one is behavioral contingencies and high-risk prevention planning. So I'm going to talk about those today. It's always helpful before I dig into CBT to ground where it fits within the stages of change model, because as we talked in prior lectures, that you really want to be matching where a person is at in terms of the course of where they are in their change process with the appropriate intervention. And so this is the stages of change model. I'm sure many of you are already familiar with this. Relapse prevention skills and CBT really start, so those are our two hubs where we're really going to be focused on applying any of the concepts or the skills or modalities we're going to talk about today. That you wouldn't apply this to people in pre-contemplation or contemplation just because they're not in a place where they're going to really want to be practicing or thinking about and applying the types of concepts that we're going to talk about. Another way of thinking about it is that really at the onset of treatment or when patients are in that pre-contemplative space, harm reduction is probably the best modality to be applying, followed by MI or ME. And then CBT kind of falls in sort of the active course of care when people are moving into action and into maintenance, where they're really focusing on learning the concrete skills that they need to change that behavior and then apply relapse prevention strategies to maintain that change. So that being said, what is CBT? Well, cognitive behavioral therapy is a talk therapy or a psychotherapy that looks really at the linkages between thoughts, feelings, and behaviors, teaching patients the ability to identify those components of their experience and being able to intervene, particularly at the level of thought and behavior. So being able to break some of the links that have been developed that are maintaining their addictive pattern. CBT in general is really, really good evidence for treating all types of substance use disorders. There have been numerous sort of gold standard controlled studies using CBT to treat numerous types of use disorder, so kind of regardless of the substance that they're struggling with. It also has good effect for treating patients that have comorbid conditions like depression and anxiety that tend to kind of come hand in hand, because a lot of the same techniques can be applied to mitigating those symptoms as well. The other nice thing about CBT is what I'm going to show you in the next few minutes is really about applying sort of the standard CBT protocol and how that's intended to be applied using the full protocol. But you can apply components of CBT very flexibly. You can kind of, regardless of your role, you can pull a particular skill or technique, go over that worksheet with them. So it's really a pretty flexible intervention that is also very effective in combination with medication or other therapy modalities. So there are cultural adaptations of CBT that could be used if you're comfortable using maybe supportive interventions or other types of interventions that you've used. You could use that in conjunction with CBT. So it's nice that you don't have to sort of pick one route with using the skills that come as part of this model. When you are applying it is sort of in a standard fashion, it is intended to be short-term and focused. So that's also really beneficial because we know that we're going to keep patients engaged in treatment and likely retain them in treatment if they're getting some symptom remission relatively soon. So most protocols in CBT, people start to feel some pretty significant symptom remission after only 6 weeks. Most protocols are somewhere between 6 and 24 weeks, or 6 to 24. The average is somewhere between 12 and 14. But that's pretty good to be able to get a significant relief within just a month and a half. This is the CBT triad. And by triad, I mean these top 3 boxes. So what this is explaining a lot of the concept that you would teach to patients in entering into a CBT protocol. And that is that, that our experiences, how we interact in the world, is sort of dictated or determined by this system, this cycle, which is bidirectional between our thinking, the emotions that we have, our physiology, and then our behaviors. And so these things are all linked together. So something can happen, whether that's an external trigger, so something in the environment, or it could be an internal trigger, so a negative emotion or a negative self-statement can activate this system. And it's important to understand this, to teach to patients, because we're not really going to be super effective at intervening at the level of emotion, which is where a lot of people sort of start with their experience. When they start noticing that something's going off, they're noticing that emotion, or particularly negative emotionality. And we're not going to intervene super successfully if we focus or enter this system just in the physiology. So where you can teach people, diaphragmatic breathing or certain techniques that can help them to increase regulation, but that's not necessarily going to result in drastic behavior change downstream. And the change that we're trying to get to support people in is decreasing their use, right? So where we are going to intervene really successfully is this relationship between thoughts and behaviors, that if we change the behaviors that somebody is engaging in, whether they think or feel or whatever way they do, that it's going to affect that entire system. And also if we change the way that someone's thinking, that is going to also affect how they feel and the behaviors that they engage in. And so those are the 2 areas that we're really hitting with CBT. In a traditional format, CBT sessions are very structured. And so clinicians really assume an active collaborative stance. What does that mean? That means that we're really trying to find that nice balance between accepting where a person is at, having unconditional positive regard for who they are and at this point in their life, but also coming to the table with, and here's some things that we can do about that. So it's not your fault that this is where you found yourself, and yet it's your responsibility to take action and actually move towards the change that you want. So really finding that balance between being overly directive and overly passive. Most sessions are structured to be 60 minutes once a week, or twice a week, depending on the intensity of the protocol, and they're divided into 20-minute subsections. The first 20 minutes is really where you're setting the stage. So every CBT protocol, each session starts with reviewing the agenda. These are the things we're going to talk about today. So that's really starting the session differently than a lot of other modalities will start a session. There's always an agenda, and that's always where we enter into our discussion. Then you do a brief review on kind of what are their current concerns, what are the problems that they've had this week since the last time you spoke to them, and what was their use behavior like, how much did they engage in that, and if there was no use, what kind of triggers or cravings may have been present, because you're trying to start to link these things together, their current sort of concerns and functioning with their use pattern. And then if you, obviously, if it's your first session, you wouldn't do this, but all subsequent sessions, you always assign practice at the end of each session. And so you would want to review that from the previous week. If we don't review it, if we forget about it, then we're no longer doing CBT. That's a core part is encouraging the practice, assigning the practice, and then reviewing it when they come back, and troubleshooting if they had any trouble with it. The second 20 minutes is where you would introduce the new skill. And what's important here is that you try to connect the dots between what you discussed in that first 20. So what were their current concerns or their use behavior with the topic that the skill that you're teaching, the topic that you're introducing. So you want to link those things for them and explain the rationale. Why is what I'm about to talk to you about important to you, and how does that connect to your current concerns? You want to try to modify the material whenever possible so that they really connect with the concepts, because if they don't understand understand it, it really is of no use. This should not be anything over their heads. This should not be academic. It should really be very practical. How can they understand applying this to their current life, seeing the value of it so that they can practice it? You never introduce a skill that you don't have time to practice in session. You don't want to just go over a handout and then send them home with it. You really want to have time to do an example together or do a role play together so that they can really feel what that's like. And that's going to increase the likelihood that they'll be successful with practice. The last 20 minutes is where you're really checking for understanding. So you want to make sure that they understood what was covered, whatever questions that they had about what was covered get answered. You go through what they're going to practice between now and the next time you see them. So you assign that practice homework. And then you'll do high-risk situation planning, which can include just concrete high-risk situation plans, which I'll talk about here in a minute, and or go over kind of their core scheduling, which is a piece of high-risk situation planning. So pull out that calendar. Let's look at what your days are going to look like over the course of this next week. How do you have it set up? What periods might there be for downtime or boredom or other situations that could pose you at undue risk, right? So doing both of those things is core to that last 20 minutes. Obviously, there are some difficulties with using CBT. A lot of it is for the client and the provider to stay focused on that agenda and not deviate too far. It's really, really easy, especially if you're switching from one means of working together to a more CBT structured means of working together, to kind of want to take that hook and go off in a bunch of other directions or deal with kind of the crisis of the moment. And it can take a lot of skill and a lot of practice to sort of validate, acknowledge that that's a struggle, and then direct them to the task at hand. Because really it is a focus on staying in what was the skill emphasis that was intended to be delivered. So we have to do a lot of problem solving, particularly around practice, dealing with any barriers or issues that could be presenting for that individual around doing things in between session, because they say the vast majority of improvement that people get has to do with that at-home practice. And then talking about sort of how to deal with stuff that comes up that's in their life, like legitimate issues and concerns that aren't being addressed by the CBT skill of that day. But doing that in a flexible enough manner that still allows you to get to the task at hand. So those are a lot of troubles that can come up with CBT. General things to keep in mind is don't be afraid to repeat. Obviously, people have done a lot of repetition, had a lot of practice with their using behaviors. And so those patterns have become deeply, deeply ingrained. And it's going to take a lot of practice with new learning, with new thinking, with new behaviors to shift out of those habits. And so don't be afraid to repeat concepts as much as is needed, or entire sessions or entire activities. It's most important that they really get and grasp and use the skill than it is that you're kind of moving through the protocol as planned. So you can repeat whole sessions, parts of sessions, whatever's needed. The other important thing is to make sure that you're always providing a clear rationale and really connecting between a patient's why they want to change, why it's important to them to make these changes, to why this particular skill set or technique that you're going to practice or piece of education even is going to be helpful to them. That if we're not always practicing and stressing that connecting of the dots, it's not going to make sense why they should adopt that new behavior or technique or challenge that thought. Monitoring is another really important part of good CBT. And there's a number of ways to do monitoring. One of them is using screeners or different symptom monitoring tools to track change over time. That's an important part of monitoring. So most CBT protocol will administer something, even if it's just a mood rating every single session to track, is there change over time? And then they'll also do things like monitoring urges or cravings, monitoring use behavior, implementing different logs or tracking sheets, which are part of the patient or the client learning how to self-monitor. Praising approximations is another really big one. So this is where we recognize the importance of positive reinforcement or behavioral contingencies. So we all respond to reinforcers. And so this is where the provider can become part of that contingency process. So looking for anything that's in the service of positive change and praising that every single time that you see it is a way of scaffolding that change over time, because we're not going to go from 0 to 100 overnight. People take however long it takes for them to make those changes. And we want to just be focused on what they're doing well versus falling back into a pattern of demoralization with how they haven't gotten where they want to be or where they're intending to go. How do you overcome certain obstacles to practice? Obviously, the main thing that we deal with in doing CBT is that practice outside of session. And that's an issue for us as well. Like I said, it can be really easy to want to fall back into the old pattern and talk about kind of whatever they're bringing in, especially if that's how we're used to interacting with them, and to shift into, okay, the last time we spoke, first off, I have to have some kind of system where I remember what I assigned and I remember what I went over with them, and then I have to cue that. And then I have to have a means of dealing with it if they did it and if they didn't do it. So failing to implement those skills that are part of CBT is one of the main reasons why CBT doesn't work. So that's kind of keeping in mind that people don't fail a therapy, but therapy fails people. Is like, well, if it's CBT has failed somebody, it's because they haven't really gotten the rationale and the hook to do that outside of work practice. So you really need to explore that as much as possible. So here's just a quick example of ways that you can kind of think about, again, coming from a positive reinforcement approach. What can I reinforce? How can we have a problem solving or solution focused discussion versus getting into an exchange where it feels punishing or negative? We never want to be like the teacher that's scolding our patient for not having done their practice. We want to be like, okay, let's talk about what got in the way. Let's think about that. Well, what did you do? Well, you thought about it. That's awesome. Okay, let's talk about what you thought about, right? You can make those different modifications as needed. So now the next few minutes, I want to talk through some examples of relapse prevention that fall under the CBT header. One of the core things that we do is called trigger identification. And this is pulling in that triad that I talked about earlier, where we're teaching people and helping them to understand that before I engage in using behavior, so I have the drink or the drug in my hand and I'm about to use it or I'm actively using it, there's a whole chain of events that occurred prior to that. And so if they can back it all the way up to the point where they got triggered, identify that those are triggers, they can learn to avoid them or interact with them differently. And then they can adopt a whole set of strategies to manage the thoughts and the urges that are connected to that trigger and stop it from getting to the point where they're engaged in the using behavior. And so one of the things that we teach is just this idea of classical conditioning. And it's important that patients really understand what's happened for them. So just like Pavlov's dogs, which I'm sure most of you are very familiar with this experiment, it's explaining to people that we have an unconditioned response to something. So something that's a natural automatic response, just like dog salivating with food. We don't have that response to certain things like a whistle, right? That's not going to create salivation. But if we link those two things, food and whistle, together, and we do that repeatedly enough, eventually that whistle alone is going to create salivation. So that happens when people engage in drug use. We have an unconditioned response to the drug itself. It hijacks the brain the way it does, and which is why it is a substance that creates addiction. And in the course of that, we have created links to hundreds of thousands of different environmental stimuli and even internal stimuli that once that link has been created, will create that same conditioned response, just like the whistle does. And so we want to use something called a functional analysis to explain to people how to get the information about their triggers. So that includes getting a lot of information about the drug set and setting and connecting that to both the short-term and long-term positive and negative consequences. So there's a lot of different worksheets out there that you can use to get that information, but that's one of the first steps to really exploring with somebody what their triggers are and how to intervene with their triggers. So here's an example functional analysis that links all of those things I just discussed together. Behavioral contingencies is the other one that I mentioned earlier about really emphasizing positive reinforcement, recognizing that people respond to consequences, whether those are positive consequences or negative consequences, that in fact, negative consequences do change behavior, but they don't change it for as long or as effectively. And so we want to be shifting people away from sort of their natural tendency or society's tendency, which is to apply shame or blame or guilt around their use behavior, that something is bad or wrong or broken in you, and allowing that kind of negative self-talk or the feedback that's coming in from their family or from society around that to be what drives their behavior. But have them think about actually, what is it that I'm trying to change? Is it my attendance? Is it my use while I'm in treatment? And what are the things that I can link to engagement in that behavioral target that can positively reinforce it? So one of the best things that we can use to opening up that conversation is exploring with people, okay, what's the triggering situation that is providing a positive consequence? So in this example, I'm going to a party with the boyfriend and using drugs at that party. I'm going to feel more relaxed, euphoric. I'm going to be able to join and be social. There's a lot of positive consequences associated with that triggering situation. So what could I do instead that allows me to still get the positive consequence, but without having to use? So not changing the trigger and not changing the positive consequence, but changing the behavior that's in between, and really having them think about, okay, it might not just be one behavior, it might be multiple behaviors, or it might be, I'm not going to go to that party. I'm going to do something else instead that's just as fun as that party would have been. But thinking about what they can do as an alternative is part of setting up those behavioral contingencies. Urge management is part of that chain as well, and that's understanding. So I have a trigger, then I have a thought, and then that thought causes an urge to use. And so the first thing that we do with urge management is teaching them that monitoring concept. So having them start by identifying the situations or the triggers that cue up that urge to use, and then starting to put a metric or a number on the intensity of that urge, because every situation is going to have a different level of intensity. And then if they can, start to also think about other ways that kind of that alternatives to use. So other ways that they can cope in that moment. There's another example of a monitoring log that links use with urges and then the situations, both external triggers and internal triggers. Once we've done that, then we can talk about the actual skill of urge surfing. So what is urge surfing? That's where we're explaining that it's just like, instead of fighting a wave in the ocean, the wave keeps coming. You have no control over the wave coming. It's part of the change process. The wave's going to be there, but you can let it knock you over, or you can surf over the top of it. Which one would be easier for you? So that's part of developing the skill to recognize that these things are natural. They're going to be there. It's not a sign of anything bad, other than you just need to implement your coping strategies. That typically they are over within 20 to 30 minutes. Even if you do nothing, even if you implement no coping strategies whatsoever, it's time limited. And every time you don't act on an urge by engaging in that use behavior, that urge gets less intense and less frequent. Now, if I've acted on that urge for repeatedly for many, many years, it's going to take a lot of time and practice for that urge to decrease in terms of intensity, but it will get weaker over time. So essentially, you become a much better skilled surfer, and then the ocean calms down. So it's a really great skill for people to understand, to help give them control over those urges rather than feeling like they're at the mercy of them. And then the last core skill that's part of solid relapse prevention is high-risk situation planning. And this is important, just like it's important why we have fire drills at work, or why there are emergency exits marked in movie theaters and hotels. We need to know where to go and what to do in case of an emergency, because when the emergency is there, when we're in that crisis state and all those emotions are high, we're not going to be able to tap into that like solution-focused problem-solving part of our brain. So the first thing that we do is we teach patients the difference between a high-risk situation and a low-risk situation. And this is going to be dependent for them, right? So it's going to be unique to their life and circumstances. So what are the situations that they are likely to use in, highly, highly likely to use in, or have used in the past? Those are high-risk situations, versus situations where they've never used, or they are very unlikely to use. That is a low-risk situation. And we want them to start to think about their day-to-day activities, how they can decrease time in high risk and increase time in low risk. And so one of the best ways to start that conversation is at the end of every meeting with somebody to pull out a worksheet like this, or even just a piece of notebook paper and write, okay, between now and the next time I see you, what situations are coming up that you are likely to be triggered to use or you are likely to use in? And let's list out those situations and let's come up with at least 3 different ways that you can handle that situation, including leaving as soon as you find yourself in it, or calling a support person, or X, Y, and Z, right? You can go through the gamut of different ideas or solutions that they have to manage that situation. And then you ask them to please keep this on them, take a picture on their phone, have this available so that when they find themselves in that situation, they can pull it out and they can implement one of their multiple plans to get out of that situation without actually using. And that's one of the reasons why scheduling is such an important part of high-risk situation planning, is because we want people to start to think through how to plan out their activities in advance so they can start to shift that balance. Because if they're really just operating on like, whatever's going to happen that day, it's really hard to anticipate the risk situations in advance. So having them start to pull out a calendar, work through like, okay, what am I going to do Monday through Friday and how I'm going to fill in those time blocks can be very useful for having them start the situation, high risk situation planning. Okay.